have an hour for the presentation and the Q&A. And I just want to welcome everybody to the CAB2 Chat and Chew, which is a community forum hosted by our Office of Community Engagement at the UCSF Helen Diller Family Comprehensive Cancer Center. We call this the CAB2 because it's not just limited to our primary CAB and the business that our community advisors do, but this is actually the public forum where we anticipate that you will invite 2 people so that we can grow our network exponentially, and so that we make sure that everybody in our networks gets this important information that we're able to bring to you in these different forums. We are going to ask you at the end to provide an evaluation. There'll be a link that we'll throw in the chat, and we'd like to get feedback from you about how we do what we do, which speakers we bring in, and how you received the offerings today. So with that, I'm going to introduce our speaker so we can hop right in. I'm really excited about this one because the Patient Advocate Foundation is not just limited to the work that is being done here in California. You'll hear more about that from our speaker, Miss Anita Reynolds, but that gives us the opportunity to expand and extend the invitation out much more broadly than just here in the Bay Area or just California. So our speaker today, we are excited to have Miss Anita Reynolds. She's a relationship manager for patient programs at the Patient Advocate Foundation. She's committed to building strong relationships with patients, healthcare providers, and other stakeholders to ensure that they have access to the resources that they need to advocate for their own healthcare needs. The Patient Advocate Foundation is a nonprofit organization, and it provides case management services and financial aid to patients with chronic, life-threatening, and debilitating illnesses. So you're going to hear a lot about what they do and how to engage with them. Please, during the course of the talk, put your questions in the chat. When we get to the Q&A, we'll let people, we'll open up the mic and let people ask their questions directly. Please use the emoji to raise your hand or raise your actual hand if you want to get a question. And we'll try to get you answers to all the questions that you have in a follow-up email. But we really, really, really want you to also fill out the evaluation. We give that feedback directly to our presenter. And so with that, I'd like to hand the mic over to Miss Anita Reynolds. And thank you so much for being with us today.
Absolutely. Thank you so much for that introduction, and good afternoon, everyone. Can everyone see my slide? At least the introduction slide?
Yes.
Perfect. Great. Thank you. So as Dr. Rhodes said, we are a national organization. We are headquartered in Hampton, Virginia, and the organization was founded in 1996. And some of you have never heard about Patient Advocate Foundation, but I can at least guarantee you at some point, if you referred a patient to another organization, more likely they were eventually referred to us. Another reason you may have never heard about us is that we want to ensure that all the funds donated to the organization goes directly to patients, which is why we don't advertise or have national commercials or commercials on social media, because we want to ensure that everything goes directly to patients, and we heavily rely on word of mouth and partnering with different organizations to kind of help spread the awareness. So that is one of the pillars of how we run Patient Advocate Foundation. Okay. Can everyone see the next slide? Next slide. I just want to make sure it's working on my end. Yes?
Yes. Yes.
Okay. Thank you. So as I stated, the organization was founded in 1996 by our founder, Nancy Davenport Ennis. And the way it started is Nancy was diagnosed with breast cancer, and she had very standard care at Duke University. However, she had a friend named Cheryl who also was diagnosed with breast cancer, a different type of cancer. However, Cheryl was facing issues and barriers with her insurance. And what Nancy couldn't understand is that how is it that 2 different women, obviously diagnosed with 2 different types of cancers, have 2 completely different experiences when it comes to their treatment. And what she saw that it wasn't fair. What happened with Cheryl was that her insurance approved a experimental trial at Duke University. Now, she lived in Virginia, so she had to travel to Duke for treatment. Unfortunately, the week that her treatment trial was supposed to start, she received a call from her insurance company that they had made a mistake in approving this trial, and they rescinded that approval. And she didn't understand how is it that an insurance company can approve something and rescind it back. And when Nancy advocated and asked questions and spoke to anyone who would listen to her, she was told, because they can. And if you don't like it, change the law. A few years later, unfortunately, Cheryl did end up succumbing to her illness. And it was at her funeral, the night of her funeral, excuse me, Nancy was at her kitchen table and realized, why did this happen? Why did treatment was delayed? Why are insurance company denying? And obviously it's not just an issue with Cheryl. So how can we help more patients? But let's also backtrack a little bit. While Cheryl was going through her treatment, they advocated for her. They spoke with anyone that would listen to them, and they were able to successfully change the law in Virginia that insurance companies were not able to deny that particular treatment if that was the only treatment for them. And then from there, they copied and pasted that same mindset and was able to change the law in several different states. And that started the policy work that Nancy did. So when Cheryl did pass away, she literally wrote the blueprint of what Patient Advocate Foundation was. And what is that? It's helping one patient at a time, helping them with finding resources, helping them with insurance appeal, disability issues, just navigating the complexity of the healthcare system. But it also was twofold, because patients are calling with issues, but what it really boiled down to was advocacy. And all of these changes were made because of laws that were being passed. So she also started in 1997 our sister organization headquarters in DC called National Patient Advocate Foundation. And what we did was all the calls from helping patients, the data that we collected, we funneled that up and said, how can we help amplify the patients' voices? So by doing that, what we wanted to do was expand our partnerships as well. And that meant, how can we advocate? How can we help patients? How can we get together to ensure that the full scope of a patient's need are met? Not just financially, emotionally, issues with their work. And we know as an organization what Patient Advocate Foundation is good at. That's helping patients with their insurance appeals, getting their resources, but we're not the ones providing emotional support. So we want to know who those organizations are so that we can refer their patients, their caregivers, and social workers as well. And then we also expanded our educational resources. So the main engagement areas PAF has is case management, our copay relief program, a few financial assistance programs that we have in partnership with other organizations, and our patient education and communications, of course, health equity, community engagement, and special events and research. So the data I'm going to provide today is from our 2022 impact report, because we're not going to release our 2023 impact until in a few months, but still the numbers speak for themselves. So since the organization was founded, you can just look at the numbers of how many patients we've served. I will say that over 1,000 were distinct diagnoses and over 600 were rare diseases. Now, when we look at different organizations, even from the ones I've spoken to, they have told me that with a rare disease, it takes longer to be diagnosed simply because of the lack of knowledge, or they just didn't know, or rare disease has too many similar symptoms as something else. So just in case management, we helped over 19,000 patients in 2022, and I'll go through every program so I can better explain what each program can do. As I stated before, we're a national organization, and if you look at the dark yellow spots, those are the, I wouldn't say hot spots, but those are the counties and the cities that we've had the majority of patients. But as we all know, cancer, chronic illnesses, and life-debilitating diseases is across the United States. So we wanted to know as an organization, how can we get into those counties that need us the most? And what that was creating my role as a relationship manager, and we're targeting the communities that we don't receive calls from. We are calling the healthcare providers, hospitals, nonprofit organizations, public health departments, and just letting them know of the resources that we provide, but also importantly, sharing resources of other organizations that can help them as well. So I want you to look at this map here, and California, I will say, it's always the top 5 states. As far as back I can go in our history, California is always the top. So I'm going to ask 3 questions. This is the first question. So I want you all to think about the questions, and if you would like to put in the chat, would be really helpful. And just think about what causes the most distress amongst the patients you support. Okay, and the next 3 questions I'm going to answer of how PAF can help maybe fill that gap or at least direct you to the right resources. Okay, it could be anything from they don't know how they're going to pay their light bill, they're scared and they need emotional support. They just don't understand how of a medical bill, how to pay for it, childcare, understanding their FMLA rights. So those are some questions that we do receive. The next question I'm going to ask, or I want you all to think about, is what causes the most distress amongst the caregivers who support the patients? It could be anything from, would my employer allow me time to take my loved one to and from treatment? Do I have enough vacation time? Do I qualify for FMLA? What am I going to do with family planning or even funeral expenses? I need emotional support to help my family member go through this diagnosis. So these are some questions that do come to mind. I may have an answer for you at the end. And then the third question is, what barriers do you all face trying to assist patients and caregivers in your community? Is it the lack of resources? There isn't enough time? Or simply, I just didn't know? So this is how Patient Advocate Foundation can help in case management specifically. So the top diagnosis is cancer. That has been the majority of patients who do call us. But like I said before, as long as a patient has a cancer, chronic, or life debilitating disease, they are eligible to contact a case manager at no cost. We don't charge anyone, patient, provider insurance, or anything at all for case management assistance. A little data about the income. The majority of the patients that did contact us had an income of under $24,000. There was an increase of uninsured patients who called us, and just a little demographic regarding our patients as well and employment. And the majority of patients who called us were seeking assistance with local rent assistance, transportation, copay assistance, and patients, how they got to us were through referrals of other nonprofit organizations, which I'm excited that 33% was that specifically. And 26% was healthcare organizations. So like I said before, we truly rely from patients being referred to us. Now, to be eligible for case management assistance, the patient must have a confirmed diagnosis or at least in surveillance or getting tested for a condition. So if a patient calls us and said, you know, I'm going through testing for breast cancer, I'm not sure if this is covered, they're eligible to contact us. They have to be in active treatment or at least in active surveillance. So if they're in remission, that's absolutely fine. They can contact us as well. Must be a citizen or legal resident of the United States and receiving treatment in the US, and need some type of access or affordability issue related to their diagnosis. So what we focus on specifically in case management is we're looking at, and I'm going to explain, we have almost 3 tiers of case managers. Those who are looking to understand how to use their insurance, those to understand how can their insurance best fit their needs for their treatment. Another level of case management are those for patients are seeking actual financial assistance. Case management does not provide direct financial assistance, but in fact, look at the whole scope and the story of the patient, whether it be their treatment that they're going through, what their income is, any medical bills that they may have, and then help assist them and connect them with any local or national resources they may qualify. Looking for transportation needs and even helping them with insurance appeals. So step 1 could be reducing financial burden, enrollment in appropriate insurance, and providing insurance navigation. So I'm going to go in a little bit deeper into that. And of course, when it comes to what we can do, of course, are things that we are unable to assist with. So a couple of them being is mental health services. We do not provide counseling or psychiatric admissions assistance. We will never provide recommendations for a specific provider or treatment or facility. We cannot help with any disputes they have with a practice or a doctor, or if they're looking for assistance with medical marijuana, CBD products, or holistic medicine, or seeking appeals for a specific doctor. We've had calls where patients their insurance doesn't cover a specific doctor, we cannot push an insurance to do that. We are also unable to negotiate medical bills older than a year. And we do not, once a patient has legal representation or it's a workers' comp related incident, we're unable to assist with that as well. So for everything we can do, of course, there are things we are unable to assist with. So some things that another thing we're unable to assist is with disputes or medical advice. We can only help guide patients and ensure that they're educated themselves to make their best decisions for them. But if it's a legal dispute, we can't assist, unfortunately. So this is a case example of a real patient that we assisted. This particular patient was a 60-year-old African-American female. She was diagnosed with breast cancer, and by the time she had contacted us, her employer did have health insurance from her employer. However, her employer was being sold to another company, and the new company was not providing her healthcare coverage. We knew already, one, she had healthcare coverage, was going to lose it shortly within the next 30 days, so she qualified for a special open enrollment. She needed to begin her radiation treatment in the next few weeks and could not afford her out-of-pocket treatment costs, and she was on a limited income as well. So those were the facts that she contacted us, and those were the things that we knew. So this is how we helped her. Like I said, she qualified for the open enrollment. We were able to find that she qualified for a subsidy of $541 to help reduce her premium. We will never tell a patient what type of insurance to pick. We will never say pick Anthem, Blue Cross and Blue Shield, or anything like that. However, we will help educate the patient in telling them this is based on your diagnosis and your income. We can help them determine that, whether it be silver, bronze, what plan fits her needs. For this particular patient, the silver plan met her needs and fit her budget. We're able to find a secondary out-of-pocket subsidy, which reduced her deductible from a little over $3,300 down to $200 a year. Arrange FMLA coverage for her half-day appointments. Initiated short-term disability with her employer. We also found a transportation grant to take her to and from her treatment. We also found a copay assistance program to help with her medications. And I also would like to state that although Patient Advocate Foundation does have a copay program, we won't always just push a patient to that copay program. We want to look at all copay programs that they're eligible for. So we help the patient apply through all the copay programs available to them. We also found a secondary grant to help at a local breast cancer foundation in her community that she qualified to help with her utility cost, and then help facilitate a contribution towards her outstanding medical bills that she already had as we're working through her case. So that was just an example of one case of many that we've helped at the organization. Another program we had is our copay program. And the way our copay program was established is every patient calling us, or not every patient, but the majority of patients calling us said they had some type of financial need, most of it being a copay program. So we had enough cases, so we decided to open our copay relief program that are on a first come, first served basis. And if you go on our website, you can see those open funds, closed funds, and they really range based on the diagnosis. We have 3 portals. Let me see if I can go back, if it'll allow me. Bear with me one moment. So our 3 portals, let's see here. Okay, can everyone still see my slide? Yes, thank you. So we have 3 portals, one for patients, one for providers, and one for pharmacies. So an example being, if you work at a doctor's office and you know a patient is about to be diagnosed or has a diagnosis and has issues paying their medical premiums or their copay program or anything, a doctor's office can log in, create a portal, and apply on behalf of the patient. Same thing with pharmacies. If you go to a local pharmacy or a pharmacist yourself and you have a patient who needs help with medication assistance, you can start applying on behalf of the patient, and the patient, of course, and the caregiver themselves. We've also have had enough feedback from other organizations. As you're helping patients, you can always give us as a resource, but when you do follow back with a patient, do they actually apply, especially if they're overwhelmed with their diagnosis or family or work? So our goal, hopefully by the end of 2025, we hope to have a 4th portal where nonprofits are able to create a login and apply on behalf of patients. So we're trying to make this as an easy and simpler process and more accessible for patients as well. So the application process is simple. It's actually instant eligibility. So the applicant will know by the end of the application whether or not they're approved or denied. And if they're approved, they're able to upload any expenses, whether it be premiums, their co-payments, and they'll also get an electronic verification card, which it's a similar to an insurance card they can take to your pharmacy, and they will deduct funds from that card as well. What's great about our program, if you're just hearing about it today, our copay program, we will actually do a 6-month look back. So an example being, if our copay of our breast cancer fund is open today, and you know a patient that qualifies and they apply, anything they've paid within the last 6 months for their diagnosis, we will reimburse them. They just need to upload their documents and we'll reimburse them. They can either mail it, fax it, or just upload it to their portal. Once we review it, we can send them a check directly as well. So copay program as well. So on average, there's been 5 contacts per approved applicant. So that means we do verify the diagnosis with the doctors. We do call just to get a little bit of verification. I also want to state, and this question comes a lot regarding income. If for any reason a patient is denied because of their income, I always encourage them to ask us to take a second look. A prime example is a realtor, especially during the pandemic. Realtors did very well during the pandemic when it comes, because they sold a lot of homes. And I had a patient that reflected, I'm no longer working because I'm going to my cancer treatment. However, my income doesn't reflect that. So I always encourage them to call us so we can take a second look and look at their current income. That's important to know as well, because if they upload their tax document does not reflect what they're currently going through, we will absolutely take a second look. So our patient education communication is, we have a couple of different types of patients or resources that contact us. And they've always said, I want you to take care of it, not a problem. I trust you and I just want the process through. But we also have those type of patients and caregivers like, I want to know what you're doing. What is the process for disability? What is the process that you're doing to help with an insurance appeal? And also social workers and other nonprofits have the same question too, and how could we use it? So what PAF did is we created our educational resource library, and we created all, if not most of our materials that anyone could use it. An example being is just because you don't have a cancer chronic illness, but you need help with a disability, if you don't qualify for case management assistance from PAF, you can use our resources to use it to be able to do an appeal yourself. It includes sample letters, how to write the appeal, and the process. We also have, because of the need that we have met with different organizations, in December, we launched our Spanish language microsite, and we're also making the commitment for every material that we create in English. As a first approach, we are also going to create it in Spanish. So if you have any Spanish language speakers who need the resources as well, we have that information available to them. And this is our Spanish resource library. You can narrow it down based on your category, educational topics, and we have webinars available at any time. And then our National Financial Resource Directory. From all the connections that we make, whether it be myself, our case managers, or anyone in the organization that we meet, we have a directory that you can narrow down based on if you have insurance, age of the patient, the state they reside in, their medical diagnosis, and their need. And what pops up, it populates, is a long list of the organizations that we know of. And you could email it directly to a patient or yourself, or be able to click and see the ones that are available in your area. And of course, if your organization isn't on the list and you would like to be added, there is a link to add your organization as well. Health equity and community engagement. So health equity has been one of the pillars that PAF has always stood on, and it's exactly what we have always done. We want to ensure that every patient gets the access to care they need, regardless of where they live and the resources they have. So what we did was, if you recall in that first map I showed that we are a national organization, you saw some white areas where patients weren't available or we didn't receive many calls. So in 2020, the CDC released their social vulnerability index. And we took that list and we saw that map and we said, we overlapped that with our map. We said, clearly there's a need in certain areas. Now, our case management program, anyone can call. You're going to be assigned a case manager if you get a call. However, our copay program is on a first come, first served basis. So an example being, if our breast cancer fund is closed today, and next Wednesday we send an email blast to all those who subscribe that our copay program is open. But if you live in a rural community or just are now learning about us and aren't able to check your email maybe once a week when you go to somewhere that has reception or have to go to your local library, whatever it may be, and you get that email and then you apply a few days later and unfortunately by then the funds are exhausted, then we saw that we're creating another barrier and just another wall. So what we did was we created our health equity zip codes. And what that is, I'll share that here, is we identified as a phase 1 approach, is we identified 226 counties as priorities. 7 of them are in California. Now, some of you might be surprised at San Bernardino County being on there. However, we will say that just because you live in the county does not mean every zip code in that county is eligible. We identified certain zip codes in all these counties. PAF will also not release the zip codes because we want to ensure that the application is fair for everyone. And the last thing we want to happen is if an organization or a pharmacist tells a patient, enter the zip code because it's going to be approved, but once we audit or we get the verification of the patient's medical diagnosis or tax or whatever documents we do get, and we realize that they're not, the last thing we want to do is have to tell a patient that they're not eligible. So truly, it has to be with the patient applying or the provider and actually entering the patient's address, and they'll be able to check. In addition to it, if you go to our copay website and look at the health equity zip codes and you enter your zip code, it'll populate and let you know if your zip code is eligible. I will say when this program started 2 years ago, we started at 220 counties, and within the last few months, we have added 6 more. And we're constantly looking at the counties and looking at the data trends, and we're adding more where it makes sense and where we're able to help those patients in need. So what we did also in addition to our counties is we created the health equity through community engagement. And what that means is Patient Advocate Foundation, like I said before, we're really good at what we know. However, we're not everything to everyone. So we wanted to do is ensure that we create a network of support or a safety net for patients. And through that is truly education and access, healthcare quality, and how can we expand the reach and also amplify the reach of other organizations. So through that is creating a one-on-one relationship between PAF and other nonprofit organizations. It's a mutual understanding that I may be in meetings that other organizations aren't. And so if I'm talking with the organization and I hear certain needs, I can refer them to our partners. And then we want to continue educate and grow not only our resources, but the resources of our partners. So we're truly looking at how can we amplify all the organizations in our partnerships. So this is a couple lists of a couple of our partners. One of them being Bay Area Cancer Connections, which is how I met Dr. Rhodes and Barbara Cicerelli. And it truly is honestly empowering everyone, making sure that every organization is in every room, whether they know it or not. It's our job to know what they're doing and how to amplify and connect them to the right patients. So there is an ask if anyone's interested of how to become a partner. I believe Lori has that information. If you have questions, you can reach out to me as well. And then our health service and research and patient experience and evaluation. So we also created what's called Patient Insight Institute. So for many years, we advocated for patients, but we also wanted to learn the experience of the caregivers, other nonprofit organizations, and the communities and researchers. So what we did was we've created Patient Insight Congress, and our next event is actually going to be in April. Yes, April in Atlanta. And this event is we're flying and we're asking people to register to this event and getting everyone in a room to give us what their experiences are as a caregivers, as providers, as social workers, or those working in the nonprofit field. What are the barriers they're facing? How can we help change policies? How can we help advocate? How can we help you advocate in your own communities? And that is actually changing how we manage our national organization and these policy levels. So here's just a story of the impact of one of our patients, David. So I'm gonna give you all a few moments to look at his story. And this is just, like I said, one of millions of, or over 1 million patients that we've helped at PAF. We helped him with the claims process and insurance, and we're able to help them find answers to some issues that they had challenges for years. And one of the questions, or one of the statements some people tell me when they hear about us is, I didn't know. And more, that's what we're trying to change, is change we no longer hear it as I didn't know. And we're going to go back to why we don't have a commercial. So if we were to have a national campaign and just had a commercial stating what Patient Advocate Foundation is able to offer, then we don't get to learn what are the needs in your community. Because as we all know, every county has a different need, every state has a different need, and every patient has a different need. So really what we want to know is, how can we help everyone? And now that is literally by going into the communities, telling them how we can help them. But also, if we can't, we want to know how can we better expand that, or at least refer them to the right organizations. So thank you everyone for your time. I think, am I over, under? So if you have any questions, please feel free to ask.
That was great. And I hope that I saw a lot of comments flying around in the chat. I don't know if you wanted to respond to some of the, what you called for in terms of what sort of things would people be concerned about.
Let me check the comments, because I had it, I wasn't able to see it when I was sharing my screen.
Oh no, we've grabbed the questions out of the chat for you, so we can start with some questions. But then if we need additional prompting, we can go back to some of those issues. I think you addressed a lot of them. There's some that you just can't address, like dealing with the existential greed and money grubbing systems inherent in all of medicine, health systems, payers, and industry, all to make a buck off of patients in their most concerning state. So I know you're not going to be able to deal with that directly. But we'll start with a question from Gary Blodger, which was asking whether or not you have a breakdown of the racial and ethnic categories of folks that you have served so far.
I do. Let me go back to that slide. Well, bear with me one moment. My computer froze, so I'm trying to see if I can get, I believed I had in that slide. And I can always provide it. I believe Lori has the slides as well that she could share out. But of course, I will say this: the data that we collect is only if the patient provides it, of course. So let me share my screen again. Share. Okay, you see that one here? I do have the ethnicity breakdown.
Okay. Great. And I don't, and Gary, if you have any follow-up, please throw it in the chat, but I think that pretty much answers your question. And thank you for sharing that, and thank you for breaking it down in that way. Another question that was in the chat was from Emily Hallgren, and the question is, are there in general income cutoffs for eligibility for the copay assistance program or other programs? And if you said that already, excuse us, but could you reiterate if there are cutoffs?
For case management, there is no cutoff. It's anyone. For copay, the majority, if I'm not mistaken, is 400% of the federal poverty guideline. And the financial aid program, I believe, is also the same, 400. I think a few of them might be 300, but most of them, if not, is 400% of the federal poverty guideline.
Great. And then just some questions are starting to come in the chat here. What happens when a patient in need has a cancer that is not listed in your choices, like a weird or unusual cancer? I'm gonna go with like a PNET, for example. There's like 8 diagnosed in the, per year. What does a patient choose in terms of a category? Is there like an other category?
Well, was it for case management or copay? So for case management, any diagnosis, cancer, chronic illness, life debilitating disease, rare disease. Case management assistance, any diagnosis in that aspect. For copay, we do have a copay specific diagnosis. And unfortunately, if we don't have the funding for a diagnosis and it's open, obviously there is any funding. We do have a list of what's called identified needs funds. So if you go on our website as well, you'll see open funds, closed funds. Those were funds that were exhausted. We're just waiting for more funds, if available, to open it back up. And then what's called identified needs funds. What those identified needs funds is we've had enough patients to call us for copay assistance with specific diagnosis. We identified a need. We created the entire copay program for it. All we need is funding. So whether it be partnering with an organization that wants to help fund it, we are constantly advocating and trying to find funding for those identified needs funds. So if you see it there, we've identified it. So I hope that answers that question. But for case management, any of those diagnoses, absolutely.
And what are your main sources of funding, since you brought that up? Is a question also that's in the chat. And I guess I want to piggyback on that and just ask, even in this circle, are you looking for organizations as they partner? Are they also being asked to partner in terms of providing some funding or support? Is there an opportunity for that?
So the majority of our fundings, just like most organizations, are truly grant applications. We're always looking at grants that might fit a program that we're trying to help in. Grants, donations from patients, donations from other organizations or communities who do 501ks, truly is in partnership with other organizations, larger organizations as well. So funding truly comes from many different avenues. I will say, obviously, to be compliant with the OIG, our copay program, no donor can tell us how to administer the funds. So if you were to donate to a specific copay program, you can't say, but it's only for patients with this, with breast cancer using this medication. Absolutely not. If they want to donate to a specific fund, they can't, but they cannot have any say of how that fund is administered. And I'm sorry, and then what was it? Oh, if an organization would like to partner to help open a funding, or let's say a financial aid program, absolutely. We have some financial aid programs in partnership, one being the Donna Foundation. They are an organization out of Florida that they do 5Ks to help with breast cancer awareness, and they wanted to provide financial support for patients. But they maybe didn't have the bandwidth to do the actual application process and help with every patient in terms of case management, but they had the funds, so they asked to partner with us to help administer their case management and also their financial aid programs. So if you go on our website and you see what's called financial aid, those financial aid funds we administer based in partnership with the organizations. And yes, if you open a financial aid program, not copay, a financial aid program specifically, I can connect you with our executive vice president of financial aid and copay and be able to discuss and set parameters. That is the only way an organization can set parameters on a funding that we administer.
And that would allow you, for example, I'm thinking of the Nova 12 walk that happens in San Francisco, and I'm not volunteering them to give their money to you, but I'm just saying, if they were to then take the money they raise, they could say, this is for women in San Francisco in the Southeast sector who are uninsured, ... And then you would administer it on their behalf.
For that, okay. Yes. And we actually have one, I'm not mistaken, one in our website that just started for Oklahoma. I don't want to misspeak, but I believe, and it's specifically for that region. The financial aid program is separate than copay, because our copay program can only be used for copayments, insurance premiums, and deductibles, and anything related to their diagnosis. Whereas financial aid program, the income varies based on what our partner program decided, and with PAF as well. And those are income. Actually, I don't want to say all of them, because we do have one pediatric amino fund that we have in partnership with Abbott during the formula shortages. And that one is not income based. That one, as long as any child, baby specifically, on a pediatric amino formula, they can apply. We're administering that fund. So it really is what our partnership with that particular nonprofit wants to choose. But if that nonprofit wants to help pay for copay, they cannot tell us it's only for women or patients in this area to help pay their copay specifically. If it's a financial aid fund, they apply and we send the check to the patient, and they could use it for whatever they see fit, whether it be helping pay for their light bill, transportation, mortgage, utility. It's whatever the patient needs it for. But copay specifically is for their anything for their diagnosis.
Okay. So we have a question about what your referral or intake process looks like, and I'm going to pair that with another question that's asking, is it okay for a social worker, for example, to open the portal and do it on behalf of the patient?
So on the copay side, it has to be a patient caregiver for the patient portal. The second portal would be the provider's office. And the third one, so if you're a social worker, I guess at a doctor's office, yes, because you're representing that doctor's office. And that third portal is for pharmacy. And like I said, our goal is to have the fourth portal for nonprofits. So if you are a social worker working at a nonprofit, yes, you would be able to help the application or start the application for the patient. Now, in terms of case management, also social worker can call us on behalf of the patient, but also understand that if that social worker contacts us and say, my name is Mary, I'm helping this patient, Eva, this is the issue they need, we cannot call Eva. The patient has to call us. The social worker can help establish the case, but at the end of the day, the patient eventually has to call us. So what I would recommend is probably when a social worker calls us is to have the patient on the line so that we can also speak with the patient and start the case from there directly. But the way they would contact us is by calling our 1-800 number, and we are open from 8:30 a.m. to 5 p.m. Eastern time.
Would you mind throwing that 1-800 number in the chat just for everybody's benefit? I'm sure it's on the slides, and we will share the slide deck out if that's okay with you.
Absolutely, yes.
Great. The two questions that pair together, I think, here are, why does a client need to be a U.S. citizen or resident? Do you have restrictions around your funding sources that drive that? And do your case managers speak languages other than English, and if so, which ones?
Yes, we do. So let me go back to why patients have to be citizens or resident of the U.S. because we have to look at what we're helping the patients are specifically is insurance appeals, access to Medicaid and Medicare, Social Security disability. So the majority of patients, if you are not a citizen or resident, wouldn't qualify for that. However, I will say this, if a patient who is not a citizen or resident of the United States and are seeking assistance, we do have a list of organizations that are able to help them. So like I said, every patient has a different need. So we also look at not just the diagnosis, but what their need are. As an organization, we have a limitation. So I will say this, during my outreach, every organization I meet with, I ask, do you help patients that are undocumented, whether it be financial resources, helping them with getting access to medications? And they tell me, yes, I add that onto our financial resource list or send that to our case managers. The last thing we want to do is promise a patient on something that we can do that we're maybe not just familiar with. So do we really want to prolong, just carry on a patient that we're not able to assist fully? But also it comes down to education and what we're trying to do as an organization. So I will say one of my tasks is I'm looking at how can we help all patients in the United States, not just those who are citizens or residents. So we are trying to look at all avenues because that question is asked over many, many times. And it's my job to document, this is a question where I'm asked, why can't we help them? Similar how we're asking the communities, well, why can't we help them? And how can we expand to help them? And I will say also one of them is the funding and an ability to, quite honestly, because the last thing we want to do as well is take the resource or educate or be able to do something for a patient that another organization is already doing better than we can or ever could. So let's refer them to the right organization. And I'm sorry, what was the other question, Dr. Rhodes?
Oh, was which languages do your case managers and do you try to match racial and ethnic or cultural concordance with the patients who are being supported?
So I will say we do have some case managers that speak Spanish. However, depending on your need, we're going to match the case manager based on the need of the patient, and we do use a language line. So I will also say we live in Virginia, so we don't have many case managers with different languages, and it really is a language barrier in our area. But we do use a language line, so regardless of what language the patients speak with, we'll find a way to be able to communicate with them.
And then there are a lot of questions in the chat related to zip code, and I think it reflects on kind of what you mentioned, whereas that, like, if your county, you know, your county looks like it's high need, but your zip code may not be high need, right? And so are there other parameters that you're using, like census tracts or something that helps you kind of, you know, get a little bit closer to understanding like where the actual social needs are, because zip code can be really tricky, especially in some of our California counties. And we see that, you know, yes, California in particular. I mean, I can't speak for other counties, but we have a lot of counties that are big and they look wealthy, but then when you drill down, you can get to some zip codes that cover territories that would qualify as high social needs on various vulnerability indices.
Absolutely. Thank you for that question, because what we did is we had to start somewhere as a phase 1 approach. So we obviously used the CDC's list, but the CDC list was very deep, and they took it into considering education level, transportation, access to transportation. So we kind of had to look somewhere of how to start. So we looked at obviously what is reported to the public health departments and also diagnoses that we assist with. So the 226 counties that we look on as a phase 1 approach, is where do we start? It's just a starting point, and we're constantly expanding it and looking at it. One example is when I flew to Alabama, and Mobile, Alabama wasn't on our list. And of course, there are people who are representing Mobile, Alabama, and they said, how could Mobile, Alabama not be in your zip code? Have you been to Mobile, Alabama? And I said, I understand. However, we're looking at specific diagnosis as a specific one approach. We're not just looking at income. We're looking at affordability issues. We're also looking at diagnosis, and not all the diagnoses that we're able to assist with. So that's how we chose that approach as a phase 1 approach. And like I said, we are reviewing it because we started at 220 counties and we just expanded to 226 counties. So in this trial and error process, we are reevaluating it as well.
Excellent. And appreciate the responsiveness to that, you know, acknowledging the reality of that for people who might need but live in the wrong place. Okay, so the big question, and you guys are all going to see an evaluation link get thrown in the chat. So we want to give you, you know, 7 or so minutes to fill out that link while you're still online with us here and the event is fresh in your mind. But our goal ultimately in convening these spaces and working with our community partners is to move an agenda for change. And that always, of course, includes advocacy, which is in your name. So I wanted to ask this brilliant question, which I love this in the chat. Does PAF support advocacy groups or other community-based organizations who are aiming to change healthcare policies in their counties? So is there some weight that PAF can kind of throw around to help move an agenda or action for structural change, which is really the, you know, the elephant in the room here, structural barriers?
What that would be is I would refer them, and if anyone's welcome to reach out to me so I can connect them with our sister organization, National Patient Advocate Foundation, because that's exactly what they're doing. They want to, because really, like I said, when Nancy started the organization, was we're helping patients, but what is the barriers of the policy issues, whether it be in their communities, their counties, you know, in statewide, and how to change that. So in the years past, so Patient Insight Congress, what used to be was called Patient Congress, where we would fly patients from every state. So we had 50 states represented, and we used to fly them all to DC and have them speak to the representatives. And we saw, okay, did that help? How did that help? And how did we help advocate on the Hill? And although it was a very successful event year after year, when COVID happened, we obviously couldn't do that. So we're like, how can we continue to advocate? And what they are pushing forward is helping advocate at community level, because it really starts, your senators come from your community and making change in that level. So to answer that question, yes, National Patient Advocate Foundation has tools to help advocacy organizations advocate for patients, help drive policy changes. And we were able to successfully change laws in a couple of different states. So if it's something of how did we do it and how can your community do that as well, or even amplify a patient story, that's exactly what we're trying to do as well.
Excellent. That is the true way to change, in some ways, to try to put yourself out of business.
And so I will say our goal is to ensure that no patient goes through this. Obviously, it's so I won't have a job. But at the end of the day, it's not going to change today or tomorrow. So how can we ensure that we're one step closer?
Excellent. So there's one last question that I'm not sure if this is, it's a little bit of clarification on the health equity funds for patients in the specific zip codes that you've identified. How are those different or additional to the general copay assistance funds?
So an example being I'm just going to bring breast cancer. So we have two funds, our national funds that's open anywhere and everywhere. So if our national fund and our health equity fund is open, so if you live in one of our health equity zip codes, and like I said, all of our funds are on a first come, first served basis. So if you happen to apply to our program and you saw that the national fund is closed, but you live in a zip code where the health equity one is, what we did is we earmarked funds for these certain patients so they have a fair chance. It really boils down to giving those patients in those areas that really needed assistance using the SVI index, is giving them a fair chance. And like I said, an example was the internet infrastructure. If you live in an area that your social worker or hospital didn't know about us, it really is giving them a fair chance. So that's how our national funds and our health equity funds are different. It's the same qualifications regarding income, diagnosis, everything is mirrored the same, with the exception our HE zip code or HE funds, you have to live in certain zip codes.
Got it. And I think we just got a link for the health equity zip codes from your website or from the copays.org part of the website. So I want to remind people to please fill out our survey, give us feedback about who you might want to hear from next. We will send out the slides from today's presentation. And as I mentioned if you check out our website on the UCSF cancer.ucsf.edu, if you plug in community, you'll find our web pages where all of our CAB2 Chat and Chew videos from the past, gosh, now we've been doing this for 6 years. Although we were in person at one point and they weren't all recorded. So since the pandemic, they're all recorded there, so you can catch it again if you missed it and share out this information, especially since this presentation does have national impact. We really invite all of you to share it as far and wide as you can, so that everybody is aware that the resources are available and that community-based organizations who want to partner are aware that they can partner through this mechanism. I don't know if you have any last words for us as we send everybody off onto the rest of their day and to fill out the evaluation. But we want to just really thank you for being here and for sharing the information about the PAF. And I also want to thank Barbara Cicerelli, Olivia Fay, and several others who at the BACC conference separately came up to me like, you have to have PAF come and give a talk at the CAB2 Chat and Chew.
Thank you so much for having me, and for everyone who did approach Dr. Rose to invite me to this amazing event, because really what we want to do is we want to amplify the patients, the caregivers, the organizations. And I hope those 3 questions that I asked in the beginning, that I was able to answer it. And if we're not able to, please let me know why, because we want to know why can't we help patients in your area, and how can we either refer you to the right partners, or how can we grow as a better organization. So thank you.
And thank you. Thank you, everybody. We will be back in 3 months. It's always every quarter that we host the CAB2 Chat and Chew. Please let us know by using the evaluation if you want to be linked up with PAF, or if you want to be continue to receive the invitations for the CAB2 events. If there are any questions, we will scour the chat. If any did not get answered, we will reach out to Ms. Reynolds and try to get the answer in writing and share that out with everybody here. But we really appreciate your feedback. It helps us be responsive to what the community is curious about and hungry for in terms of information to reduce disparities and advance health equity in cancer. Thank you, everybody.